हो गया? आया तो नहीं अभी तक यूट्यूब पे? मैं भी देख रही हूँ। आ गया? आ गया अनिल भाई? ओके, मुझे क्यों नहीं दिख रहा? A very good evening to everyone. I'm Dr. Divya Gupta, Periodontics Mentor at DBMCI MDS. So, before beginning the session, first of all, I would like to congratulate all the rankers of INI CET May 2024. So, heartiest congratulations to all the rankers. And I hope that all those of you who are seeing me today live on YouTube, next year we'll have rankers from you all. So with that said, let us start this session of periodontics. So guys, we will be together for 15 days. Starting from this 25th May, we will be together till 10th May. So first of all, I'd like to tell you how we will go about these sessions, okay? So I have created a group of doubt clearing session on Telegram. So kindly scan this QR code which is shown on the image on your screens, right? Please scan that and post all your doubts related to periodontics in that group only. At least till 10th or till 15th of June, till the time we are together, right? So that it becomes easier for me to connect with you all and to clear your doubts immediately. Otherwise, what happens is sometimes when we are in different groups, there are different groups, right, for DBMCI on Telegram. Now what happens is sometimes we miss some questions, so I don't want to miss any of your questions, any of your doubts. So guys, first of all, just scan this QR code and join that group, okay, Telegram group. Next thing is uh, I'll tell you what all topics we will be covering, okay? And after each session, means suppose today we are going to study about the normal periodontium, right? The anatomy of the normal periodontium. So after completing the class or how I'll take the doubts, I'll not take the doubts in between because that breaks the flow of the whole chapter, right? So I'll take the doubts 5 minutes before the break, 5 minutes after the break. And after we complete the session, so approximately after 1.5 hours of class, we'll take one break of 10 minutes. So I'll be solving the doubts in 5 minutes before and after the break. And also at the end of the session, we'll take approximately 5 to 10 minutes to solve the doubts at the end of the session. And also I have made whatever we will be learning today, right? Whatever we will be learning today, I have framed 10 questions. I have taken 10 PYQs, previous year's questions related to this topic, which if we will have time, we will discuss them. If we are not able to discuss those 10 questions, I'll post it in this Telegram group only so that you can answer those questions in the group. If you have any doubts related to those questions, you can ask there, or else we can discuss those doubts in our next class. Okay, that will be tomorrow. So this is how we will be going through our sessions of periodontics and the topics which we will be covering. The topics which we will be covering first. So there is a sequence. Means first what will happen? First you have to learn about the normal anatomy of the gingiva, then the etiology, then the host response, so that you will be clear with the concepts. Because nowadays questions not direct questions are coming for NEET or either INI. In the recent paper only we saw that many of the conceptual questions were there. Okay, so we have to shift our study towards more conceptual study, and I feel that perio is a subject in which some of the concepts, specifically related to surgical part of the periodontics are not clear for students. Even the normal anatomy of the gingiva, if question comes from that, some of the students will be having doubt on in that also, because we get confused between probing depth, pocket depth, clinical attachment loss, CEJ, everything. All these are very confusing terms, and when we have to study all the 19 subjects together, we have to select what all things we have to study, right? So today or throughout these 10 to 15 days, 10 actually the class is till 5th, and after that PCT discussion is on 10th, right? So first what we will be doing is the normal anatomy of the gingiva. Okay, normal anatomy of the periodontium. Anatomy of periodontium. Then there will be periodontal microbiology, means we will be studying about the primary etiology of gingival inflammation. Periodontal microbiology, which covers dental plaque and dental calculus. After that, host response and inflammation. Host response, this is very important topic, because if you are clear with the concept of host response, you will be able to answer many questions related to systemic diseases that are being asked. Okay, in the recent INI also there was a question related to heart disease. There was how periodontitis and heart disease are linked. Okay, how periodontitis and diabetes are linked, how periodontitis and pregnant female oral changes in the pregnant female patients are linked. Such questions are very important for our exams. Okay, so after reading this chapter, this topic particularly, you will be clear about those things. Then then we will be studying about the gingiva in disease. Gingiva in disease, in which we will be covering gingivitis, chronic periodontitis, aggressive periodontitis, acute gingival infections, trauma from occlusion. Okay, in that we will be studying about the bone loss patterns, also TFO. Okay, then there are systemic conditions and diseases related to gingiva. Systemic conditions related to gingiva. Then the risk factors. In risk factors, we will be studying about smoking majorly. Smoking is also one of the most important topic. Then the phases of treatment plan. Treatment plan. Sorry. Then the surgical part of periodontics. Surgical part, where we will be covering about the periodontal flap surgeries, mucogingival surgeries. I will be showing you videos specifically related to various incisions. Okay, images. There are many images in mucogingival surgeries. There are many images in surgical part, periodontal flap surgery. We will be studying about periodontal regeneration. Then the non-surgical treatment, non-surgical non-surgical treatment of periodontics, which covers plaque control, LDD, HMT, host modulation therapy, local drug delivery. All these topics are covered there. And lastly, we'll be studying about the miscellaneous things. Miscellaneous may what all things we will be covering? Miscellaneous topics covers laser surgery, electrosurgery, then some aspects of piezoelectric surgeries. Okay, all these things and some parts of implants will be covered in your miscellaneous topics. So with this idea, let us start our first topic, which is anatomy of periodontium, normal periodontium. Okay. uh, okay guys, keep posting your doubts. I hope you all have joined the Telegram group. So I'll be taking your doubts there only, guys. Okay. I think the YouTube session will be of about 1 hour 15 minutes or 1.5 hours. So by that time you can. Okay, I'll show you the scan once again, and please post your doubts there. Okay. I I'll be sharing this scan in our other groups also. And please, I request you all to share your doubts there only, so that it will be more clearer and things will go more smoothly. Okay. So just take a screenshot and join the group. Even the link is there. If you're not able to scan, type the link in the Google and you will be able to join it. Okay. Now, let us start with the class and our first topic, which is gingiva. So, what is gingiva? Gingiva is a part of oral mucosa. Gingiva is a part of oral mucosa covering the bone, root surface, and perial space of the tooth. And perial space of tooth. Okay. So, there are several different parts of gingiva, and each part has its own significance. So, so guys, this is the tooth. Okay. This is the tooth. Here is the gingiva. Here is the bone, cementum. Okay. The first thing, this crestal part of the gingiva is the free gingival margin. Free gingival margin. It is called free because it can be easily separated from the tooth, and it lies on the outer aspect of the sulcus. Okay. From this free gingival margin, in approximately 50% of the patients, there is presence of a groove. There is presence of a groove which is called as free gingival groove. Guys, I'll solve your doubt later only. So just post it in the group or on the YouTube. I'm not seeing the YouTube session right now. Okay. I'm just focused on teaching right now. Okay. So the free gingival groove, this is very important. The free gingival groove is present in 50% of the patients only. In the remaining 50%, then how we determine the location of free gingival groove? So what we do is we take our probe and penetrate the probe inside the sulcus. So where is the sulcus? This is the sulcus, right? This is the sulcus. So we take our probe and insert it into the sulcus, and the depth up till which the probe goes, when we penetrate the probe, we will see some sort of projection at this end. We'll see a projection on the outer surface. From there, we can determine that this is the height of the, or this is the location of the free gingival groove. Below the free gingival groove, this much part, from the free gingival groove starts our attached gingiva. Okay, this yellow part is your, attached gingiva. Why is it called attached? It is called attached because it is attached to the underlying bone, and it is very firmly adherent to the underlying bone. It cannot be moved. So the attached gingiva extends from the free gingival groove up till the mucogingival junction. So where is your mucogingival junction? This point is your mucogingival junction. This is your mucogingival junction. Now, when a patient is coming to you, how will you identify? It's not only present in patients, okay guys, it is present in everyone. Even right now, you can look into the mirror and you can see where is your mucogingival junction. So this mucogingival junction is a point of attachment. It is a point of attachment and it is a junction between the attached gingiva and the alveolar mucosa. This is your alveolar mucosa. It is mobile. Attached gingiva is firm but alveolar mucosa is mobile. Okay, remember this point. This is your alveolar mucosa. Why is it called alveolar mucosa? Because this is the mucosa covering the bone. So it is called as alveolar mucosa. And how will you identify this mucogingival junction? So to identify this mucogingival junction, there is a test. How to identify the mucogingival junction? How to identify? So the short form is mucogingival junction. Mucogingival junction is by the tension test. So what we do, we move the lip outwards and forwards. Okay, we just protrude the lip and move it outwards and forward in this way. So you will moving and the attached gingiva is firm. So that line, that junction between the mobile and the immobile gingiva and mucosa is called as mucogingival junction. Okay, so I'll show you a video and it will be more clearer to you how it happens. So this is a video. This is a video from YouTube only. So here you can see okay. Now see in this video, the doctor is showing you how you can identify this mucogingival junction. Okay. So here you can see this is with the help of the probe. She is showing you the free gingival margin. This is the interdental papilla and this reddish line, this pink, coral pink gingiva and the reddish alveolar mucosa. You can see a line there, a thin line like this line. This line is your mucogingival junction. Okay. Now with this is the tension test. The patient, the doctor is with the, you can see here that this mucosa is moving, right? When she is taking the probe from upwards to downwards, she is putting some pressure on the frenum, right? And see the above mucosa, the gingiva, the attached gingiva is not movable, but the lower alveolar mucosa is movable. So that is your mucogingival junction. Okay. Now, here with the help of the probe, I'll go a little bit forward. See. Now, the width of attached gingiva, what is keratinized gingiva, that I'll tell you. Don't worry. You just right now see how she is doing the tension test. Okay. See, this way. By pulling the lip outward and forward to determine the movement of gingiva. Okay, this is how a tension test is performed. Okay, so now with the help of a tension test, we can determine the location of mucogingival junction. The other method of determining the mucogingival junction is with the help of roll test. In roll test, what we do is we take the probe, not the explorer, the probe, because it has a blunt end. So it will not injure the gingiva. So we will take the probe and move it from downwards to upwards, right? From downwards to upwards, we'll move it. So the mucosa, the alveolar mucosa is mobile and the attached gingiva is not mobile. So that junction we can easily identify, and that will be your mucogingival junction. So these are the two important points of identifying the mucogingival junction. Next comes the attached gingiva. Important points regarding the attached gingiva which are asked in exams. I'll be writing AG instead of attached gingiva now. Okay. So in attached gingiva, the most important point is the width of attached gingiva. This width which we are seeing here, this width is very important. So attached gingiva width is highest. It is highest in maxillary central incisor, which is 3.5 to 4.5 mm. Next, it is highest in mandibular central incisor. Sorry, maxillary premolar. Sorry, guys. Huh? Maxillary premolar. Next, it is highest in mandibular premolar. Sorry. There is a mistake. It is highest in central incisor only. Maxillary central incisor is 3.5 to 4.5 and mandibular central incisor is 3.3 to 3.9 mm. It is lowest or it is least in maxillary premolars, okay? In maxillary premolar, which is 1.9 mm, and mandibular premolar, which is 1.8 mm. So these values are important for your MCQs. This you have to remember. Okay. Now, the width of attached gingiva, it increases up till 4 years. The width of attached gingiva increases up till 4 years, then it becomes constant. But it has been seen in aged patients because of attrition and everything. Sometimes in some aged patients, the width of attached gingiva increases due to passive eruption, about which we will be studying in the age-related changes. Okay. So width of attached gingiva increases up till 4 years, and in supra-erupted teeth. Supra-erupted teeth. Now, what happens here? How the width of attached gingiva increases? The width of attached gingiva increases because the mucogingival junction is constant throughout life. This is another important point related to mucogingival junction. The mucogingival junction remains constant throughout life. Okay, it does not changes. So because of this, as the teeth are getting treated, or there is supra eruption of teeth, whether there is increase or decrease in the width of attached gingiva, because only at this level changes can happen. Below this, below mucogingival junction, the changes cannot happen. The changes can happen at this level only, because the mucogingival junction is constant throughout. Now, this whole gingiva from the free gingival margin up till the mucogingival junction is called as keratinized gingiva. This whole margin of gingiva, this whole part, okay? This whole pink part is called as keratinized gingiva, okay? And this keratinized gingiva, the width of keratinized gingiva should be minimum 2 mm. The width of keratinized gingiva should be minimum 2 mm. If it is less than 2 mm, the chances of gingival inflammation increases, because what will happen, as there is more tissue loss, as there is loss of tissue, the plaque will be nearer to the bone, nearer to the connective tissue, and it will cause more of destruction. If this width is less than 2 mm, what will happen? The location of free gingival margin will be here. So more and more plaque will get accumulated here, and it will be nearer to the bone. So it will be able to cause more destruction of the bone. Okay. Now, this is the width of keratinized gingiva. Now, width of attached gingiva. Minimum width of attached gingiva is 1 mm. If it is less than 1 mm, the chances of connective tissue destruction and bone destruction increases. Okay. It will influence the bone destruction. Now, there is one common question which is asked on gingival biotype. What is gingival biotype? Now, gingival biotype. Gingival biotype. Gingival biotype is the thickness of the gingiva. It is the thickness of the gingiva. There are two methods of measuring the gingival biotype with the help of the probe. Most commonly, we use UNC 15 or UNC 12 probe to measure the gingival thickness. This thickness which you see here, right? This thickness is measured with the help of gingival. This is called as gingival biotype. This thickness of whole of this thickness is called as gingival biotype. Now, one image-based question was asked in the previous year's question, which was about this. Identify the image. Okay, the question was identify the image here. So here in this picture, first I'll tell you about this picture. This is the clinical image of a person, right? A normal healthy gingiva. Now in this normal healthy gingiva, here you can see this grooves, right? This is a very ideal case, guys. Not in every case you will see such type of grooves. Remember, it is present only in 50% of the cases. So here, this line which you see here, this is your free gingival groove. This is the free gingival groove. This difference in the color, right? This is your alveolar mucosa and this is the attached gingiva. This junction between the this is the attached gingiva. This junction between the attached gingiva and alveolar mucosa, this junction, this is the mucogingival junction. Okay. Here is the frenum. This is the buccal frenum. Here will be the labial frenum. Here is the maxillary labial frenum. Okay. So these are the parts which you will see from the outside, outside of the patient's mouth. Now this was asked in one of the PYQs. What is this instrument which is shown in the image? These are the color view probes. These are the color view probes, and these probes are used to check the thickness of the gingiva or the gingival biotype. One method I told you is the periodontal probe. A marked periodontal probe such as UNC 15, it has marking till 15 mm, right? So what we'll do is we will anesthetize the area. We'll give infiltration to the patient where we want to measure the gingival biotype. and we will insert the probe perpendicularly, and the depth up till which the probe the probe is penetrating, suppose 1 mm, 2 mm, 3 mm, based on that we can judge how thin or thick is the gingiva. Now what is the significance of this gingival biotype? Specifically in cases of implants, when we have to place an implant, so we have to do a treatment planning before implants, right? So we'll just check how much, and in cases of flapless implants, we'll just check how much amount of gingiva is present covering the alveolar bone. If it is 2 mm, then we have to keep that 2 mm into our mind before drilling the, suppose we have to place an implant of 12 mm, flapless case we are doing, and we have to place an implant of 12 mm. So my drill should go up till the depth of 14 mm, right? Because I have to consider the 2 mm of the gingiva. So that is why gingival biotype is important. Also in the cases of recession, sometimes in orthodontic patients, there are more chances of recession, right? If we do not calculate the gingival biotype very nicely. So what will happen? If we just check and we feel that in the central incisor, the gingival biotype is thin. So we must explain to the patient that in future there are chances of gingival recession. So the patient is aware कि हाँ ये हो सकता है मेरे मुंह में, right? This is what is the significance of gingival biotype. That's why we are measuring the gingival biotype. So in gingival biotype, this is one of the instruments. One is periodontal probe. The other is this color view probe. So in this color view probe, what we do is we take the probe, and first we take this is the sequence of the probe is, this is number 1 probe, this is 2, and this is 3. So first the number 1 probe, that is with the black band, is inserted inside the sulcus, and the light is reflected. The light is kept onto the gingiva. If the white color of the inserted part is visible from outside, okay, then it is a thin gingiva. It is a thin gingiva. Okay, if white color visible, gingival biotype is thin. Okay, if it is not visible, if if this white color is not visible, we will move to second number probe, which is this. Sorry, this is the third probe. Sorry, this is the third probe. This is the second probe. So we'll now take the green color probe, and we will insert this green color probe. We will throw the light on the patient's gingiva. If this green color is visible, okay, if this green color is visible, green color visible, then the biotype of the gingiva is medium. Okay. If this green color is not visible, we take the third probe, which is this blue probe, and then if the blue color is visible, blue color visible means thick biotype, and this blue color, if it is not visible, then the gingival biotype is very thick. If blue color not visible, then gingival biotype is very thick. Okay. So this was about the attached gingiva, the mucogingival junction, alveolar mucosa, okay, free gingival groove, free gingival margin. These were the important points related to this topic. Now next comes the gingival sulcus. What is gingival sulcus? So this V-shaped space which you see here, this V-shaped space, okay, this V-shaped space is your gingival sulcus. What is the importance of this V-shaped space? In this V-shaped space, so gingival sulcus is a V-shaped narrow space surrounding the tooth. Okay, it is surrounding the tooth. Now, in this V-shaped space, there is GCF. And GCF is an inflammatory exudate. So, some amount of inflammation. You must know that oral cavity is not sterile, or microorganisms, the bacteria are present into the oral cavity. So, some amount of inflammation is continuously going on in a patient. Whether or not it is visible, it depends upon various other factors, but some inflammation is going on, and thus the GCF is produced continuously and it is into the sulcus. Okay. Now, in gingival sulcus, if this gingival sulcus, this is non-keratinized. Gingival sulcus is a non-keratinized epithelium. The epithelium of gingival sulcus is non-keratinized. What is non-keratinized? What is ortho and para-keratinized? That we will be studying later. But remember that gingival sulcus is non-keratinized and it is a semi-permeable membrane. It is a semi-permeable epithelium. Means some parts, some molecules from the connective tissue can easily pass into the gingival sulcus. Some inflammatory molecules which are produced inside the connective tissue because of the destruction of connective tissue, because of the destruction of the bone, can come out into the gingival sulcus and from gingival sulcus into the saliva. Okay. Now this gingival sulcus, if we cut the gingival sulcus and if it is exposed to the oral cavity, if it is exposed to the oral cavity means what? If this gingival sulcus is means we cut the periodontal flap, we cut the flap, and if it is exposed to the gingival sulcus, then this part, this gingival sulcus has the ability to get keratinized. Okay. So if gingival sulcus is exposed to outer oral environment, it has ability to keratinize. Okay. Now the next important point for MCQ is, all the important points for MCQ, mostly I'll be writing it in red. Okay. So the histologic depth, how we'll calculate the sulcus depth with the help of a periodontal probe. So there is an ideal depth. What is the ideal depth for gingival sulcus? It should be 0 mm. But ideal depth is not possible. 0 mm depth of sulcus is not possible because it is not a sterile oral cavity. Germs are microorganisms, bacteria are present surrounding the sulcus. So it cannot be 0 mm. Now the histologic depth. These terms are very important, guys. Write it down in your 20th book. I hope you know what is your 20th book, right? So all the 19 subjects, some things are conceptual, some things have already been proven, that you need to remember. There are some classifications, specifically there are many classifications in pharmacology, dental materials, right? So you need to remember those classifications. There are few classifications in other subjects also. So you need to remember those things. So the things which you cannot apply your concepts, those things which you have to mug it up, you can write it down in an other book, in your notes, right? Write it down there and try to read that book as many times as possible, every day at night before going to bed, whatever is your schedule, right? You can, before going to bed, or even if you are an early riser, whenever you are getting up, just go through that pages, because if that book you are seeing daily, everything will be here in your mind, and if you will get an MCQ related to that topic, it will be very easy for you to remember, right? जैसे हमें हनुमान चालीसा याद हो जाती है, if we continuously play something on TV, on phone, we remember it, right? Our brain has that capacity. Don't try to mug it up, just go through, just see it once. and it will be there in your brains. So just after this class, if you those of you who have not made a 20th book, make a 20th book and write all the important points there, the things which you can forget, which are volatile. Write those points in your 20th book. Okay, guys? Okay, the histologic depth. The histologic depth of gingival sulcus is 1.8 mm. And the probing depth, the clinical probing depth of gingival sulcus is 2 to 3 mm. Is 2 to 3 mm. So this is the important depths which you need to remember. Now, another question that usually comes is on the clinical attachment loss or clinical attachment level. Clinical attachment level. So what is this clinical attachment level? See, here you see that this sulcus is attached up till CEJ in a healthy gingiva. But whenever there is a periodontal pocket present, whenever there is recession present, in such cases what happens is this junctional epithelium shifts downwards. Okay, and there is the clinical attachment level is increased, right? There is loss of clinical attachment of the tooth. See, if I'll just show you with the help of an image. So what happens if this is the tooth, okay? And here is a periodontal pocket. This is the pocket. So what is the ideal location of CEJ? What is the ideal location of sulcus? It should be here at the CEJ. But now you can see that it has receded till this much depth, right? It has receded till this much depth. Suppose this is 4 mm. So what is your clinical attachment loss in this case? Clinical attachment loss is 4 mm, guys. This 4 mm is your clinical attachment loss. Very important topic because numerical questions are come from this topic. Okay, so you must know how you will calculate this clinical attachment loss. So if we take a probe, right? In the exam, mostly how the questions are asked given are, this is the probing depth. The probing depth is up till the apical penetration of the probe. This probing depth, suppose, is 7 mm. Okay. And they will give you the distance from free gingival margin up till the CEJ. This distance they will show you in the image. Suppose this distance is 3 mm. So, and now they will ask you to calculate the clinical attachment loss. From here, the attachment loss is this much. So, the clinical attachment loss will be probing depth minus this, right? The distance from free gingival margin till CEJ, which is clinical attachment loss. I'll write it as small l. So, clinical attachment loss will be 7 minus 3 is equal to 4 mm. Okay, I hope it is clear how to calculate the clinical attachment loss. Now, this was a case of pocket depth, periodontal pocket, in cases of periodontal pocket. Periodontal pocket. This was scenario number 1. Now comes scenario number 2. In scenario number 2, there is recession. Scenario number 2 is recession. This was the case of periodontal pocket, where a pocket is present, where a deep pocket is present. Now in case of recession, what will happen? If this is the tooth, okay, and here is the recession. So here the probing depth, the clinical attachment loss. What is the clinical attachment loss in this case? The clinical attachment loss in this case is this much, guys, from the CEJ up till the base of the pocket, right? This is your clinical attachment loss. Now here they will give you this distance, the pocket, the probing depth is equal to 2 mm. Okay, the probing depth is equal to 2 mm, and the distance, suppose they have given the distance from CEJ till the free gingival margin. This distance is, suppose this distance is 4 mm. Then in this case, what will be your clinical attachment loss? So in this case, the clinical attachment loss is equal to pocket depth plus this distance plus 4 mm. So pocket depth is 2 mm plus 4 mm is 6 mm. So your clinical attachment loss is 6 mm. Okay, I hope this is clear. Now let us see the case of a third case where there is a supra-bony pocket present. Supra-bony means there is a pseudo pocket present, not supra-bony, there is a pseudo pocket, means there is gingival enlargement. So in that case, what will happen is, in cases of pseudo pockets, in cases of pseudo pocket, what will happen here? If this is the tooth, here is the CJ. Now in pseudo pockets, there is no bone loss, but the gingiva has enlarged, right? So in this case, do you think there is clinical attachment loss? No, guys. In this case, clinical attachment loss is not there. So there is no clinical attachment loss. Okay. Now, if there is a supra-bony pocket, suppose I'll discuss with you every scenario, so that even if the questions are twisted, you will be able to answer them. You should be clear with the concept. I hope now you are clear what clinical attachment loss is, because I think many of you find it difficult, right? Okay, what clinical attachment loss is exactly. So if this is the, okay, I'll write the gingival pocket, gingival enlargement plus pocket. If there is gingival enlargement plus pocket. So if this is the tooth, here there is enlargement also and pocket also. So here the pocket depth is 10 mm. Okay, the pocket depth is 10 mm, and this much, this distance from the CJ, they will give you. So the clinical attachment loss here, the clinical attachment loss here is this much, right, guys? It is this much. This can be asked in image-based questions. So the clinical attachment loss here is this much. This is what your scenarios can be. Okay. Now the next topic is the interdental gingiva. Interdental gingiva. What is interdental gingiva? The gingiva that is present between, in the gingival embrasure between the teeth, is the interdental gingiva. This is the interdental gingiva here. This triangular shaped area which you see here, this is your interdental gingiva or interdental papilla. Okay. Now this interdental gingiva is, interdental gingiva, it is pyramidal. This is important for MCQ. It is pyramidal and relatively easy point. It is pyramidal in shape in anterior teeth, pyramidal in shape in anterior teeth, and it is tent shaped in posterior teeth, and this change of shape depends upon the contact point of the tooth. The contact, where the contact between the two teeth is present, determines the shape of the tooth, shape of the interdental papilla. Now, if this is the posterior teeth, okay, if this is the posterior teeth, here is the contact, so the gingiva will be like this. The gingiva will be like this. Okay, so this is the tent shaped gingiva. We are seeing the teeth from the proximal aspect, right? And this is the contact point. Here is the contact point. So this is your tent or caul shaped. Now this center portion which you see here, this center portion is called as caul, and it is a non-keratinized layer. It is a non-keratinized area, and this area is, it accumulates maximum amount of plaque because our brush cannot reach there, accumulates. Even our scalers, it is difficult to reach in such tight in contact areas. Okay, so accumulates maximum plaque, therefore more prone to infection, more prone to infection and clinical attachment loss. And this clinical, whenever you will have a patient of periodontal pocket, you will see that in majority of cases, maximum amount of deep periodontal pockets are present in the interproximal region only. This is because this area is most susceptible to infection, periodontal infection. Now, we are since long we are talking about the pocket depth. We are checking this pocket depth with the help of a probe. So you must remember that the probe should be inserted into the sulcus with a specific amount of force. So that force, probing force, this is also important point for MCQs. Okay, so the probing force which should be used, the probing force which should be used or can be well tolerated by patients is equal to 25 grams. Okay, it is 25 grams which can be well tolerated by patients. Okay, so now here we have completed the major macroscopic features of the free gingival. The major question relate topic such as the free gingival margin, the attached gingiva, alveolar mucosa, mucogingival junction and sulcus. The junctional epithelium I'll be taking afterwards. Now let us come to the microscopic features of the gingiva. The microscopic features of the gingiva, which are also very important. The microscopic features of gingiva. So the gingiva consists of, if this is the outer oral epithelium, so gingiva consists of, this is the oral epithelium. Okay, here the cells are there. We will be discussing about the layers and everything. This is the connective tissue. Okay, this is the papillary layer of the connective tissue, and this is the radicular layer. This is the papillary layer. Papillary layer. Papillary layer. And this is the reticular layer. Okay. Now the gingival epithelium is, first let us study about the gingival epithelium. This gingival epithelium is of three types, which is outer oral epithelium, outer oral epithelium, sulcular epithelium, and junctional epithelium. We will be studying about all the three epithelium one by one. First, let us take the outer oral epithelium. First, let us take the outer oral epithelium. This outer oral epithelium, it has four layers. Specifically, it has four layers. So, let us study this with the help of images. Okay. So here in this picture, you can see that here in this picture, this is a stained section of the oral epithelium, and you can see that here, this is the outer oral epithelium, right? This is the outer oral epithelium. And here is the connective tissue. This is the connective tissue. The outer oral epithelium is divided into certain strata or layers, which are at the base. At the base, you have the basal layer. The basal layer. The cells of the basal layer, the major cells of the basal layer are keratinocytes. These are the keratinocytes. Okay, they are very active cells. The major cells of the basal layer are keratinocytes. Okay. Now these basal layers, the function of these keratinocytes is, there are two functions. Number one function, it will take the nutrition from here, from below this is the connective tissue, right? Remember this. Below the keratinocytes is the connective tissue. Now what way they will do is, they will take the nutrition from here and they will supply that nutrition to the above layers of the cell. Plus this keratinocytes are the major cells which divide. So they have a high mitotic activity. They have a high mitotic activity. The cells in this layer have a high mitotic activity. These cells are called as stratum basale. The cells here, this layer is called as stratum basale. Okay, because it is at the base. So it is called as basale. The major cells of the oral epithelium are keratinocytes. Just remember this. Okay, so the cells here are, each individual cell is an individual keratinocyte. And the layer is called as, the layer which is formed by these keratinocytes is called as stratum basale. Apart from keratinocytes, there are other non-keratinocytes which are also present, about which we will be studying. Okay, so these keratinocytes, they have a high mitotic activity. So anything which has a high mitotic activity, try to think in this direction. It will have large amount of organelles, right? Because it has to do cell division. So it has high activity, it requires lot of energy. So energy is available through food, nutrition. So that nutrition, it derives from the underlying connective tissue, from the blood vessels, because it is in direct contact with the blood vessels. Plus it has large number of organelles. Large number of organelles. Cellular organelles. Now, after this, some cells will remain. Some keratinocytes will remain in the basal layer. Other keratinocytes will go up and form the second layer, which is stratum spinosum. So these cells will come and they will form the second layer, which is the stratum spinosum, like this. Okay, so this second layer, it is called as, stratum spinosum. Why it is called as spinosum? Because whenever this section, these cells are looked in histological section, because of what we take the tissue and we stain it. First we have to dry it. So because of the drying, what will happen is the cells will shrink. The cells in this layer will shrink and they will remain connected at the intercellular junctions, right? These intercellular junctions, they are called as desmosomes. So they remain connected here and other parts shrink. So they appear star-like or spine-like. So that's why they are called as stratum spinosum. And the important property which you must know of these cells is that these cells have something called as Odland bodies. These cells, this layer has Odland bodies. Odland bodies or keratinosomes, and the function of these keratinosomes is to produce acid phosphatase. The function of this layer or these keratinosomes is to produce acid phosphatase. What is the role of this acid phosphatase? This acid phosphatase, it will destroy the cell membrane and the cell organelles of the next layer. So the next layer is more oval in shape, and here the destruction of the cells and the cell organelles start. So the next layer is called as stratum granulosum. It is called as stratum granulosum. It has large amount of granules present. These granules are called as keratohyalin granules. Whatever I am saying, guys, it is very important. Here the nuclei is pushed towards the periphery. In this layer, the nuclei is pushed towards the periphery. There is destruction of the cell organelles, and the important granules here are keratinohyalin granules. Keratohyalin granules. These granules, what will happen? These granules are responsible for forming the topmost layer, which is the corneocyte matrix. So what will happen? You just see the sequence. First, there was basal cell or the keratinocytes, which was highly active. Now what is happening is the cells are becoming more oval in shape and the number of cell organelles are decreasing. Okay, the number of cell organelles are decreasing. Apart from that, stratum spinosum is producing acid phosphatase. The Odland bodies in the stratum spinosum are producing acid phosphatase. This acid phosphatase, it destroys, this acid phosphatase, it destroys cell membrane and organelles which are present in the keratinocytes in the upper layer, which is the stratum granulosum. So here what will happen is the cell organelles will start getting destroyed. Even the nucleus is pushed towards the periphery, and slowly the membrane will also be destroyed. So as the cells are reaching upwards, what is happening? The membrane is getting destroyed. So suppose there is a balloon. Okay, imagine a balloon. Imagine this is a balloon filled it with water. Okay, now I'm bursting that balloon. What will happen? All the water will spill. Similar thing happens with the here with keratinocyte. What will happen now? Because of the release of acid phosphatase, what is happening? This cell membrane is getting destroyed. This cell membrane is getting destroyed and the cell organelles are getting destroyed. So whatever matrix is there, cytoplasm is there, that is getting deposited here, right? The nucleus is also destroyed by the acid phosphatase. Everything is destroyed. So the topmost layer is the stratum corneum. The topmost layer is the stratum corneum. The cells here are called as corneocytes. See, don't get confused. Keratinocytes are, these are the keratinocytes only. But as they are present in the stratum corneum, they are called as corneocytes. A different name for keratinocyte only. But this keratinocyte does not has a cell membrane. Here there is no nucleus, completely destroyed nucleus. It consists of matrix, and this matrix is rich in filaggrin protein and keratolinin. These are the proteins which are present in the superficial layer of stratum corneum. These provide the firm adherent structure which is resistant, which provides a physical barrier which is resistant to trauma. This is the layer which is resistant to trauma, stratum corneum. Okay, in this guys you need to if I hope you are clear with these terms, what is the role of these uh, cells in each layer. This process of migration of cells from basal layer to the topmost layer, this process is called as keratinization. This is called as keratinization. Okay, it is also called as cell turnover rate. Cell turnover, cellular turnover, right? As the cells are migrating, what will happen finally? This layer will shed off and again a new layer of corneocytes will come. Okay, so it is called as cell turnover. It is also called as maturation. Maturation. Okay. So now let us see what, based on the process of keratinization, based upon this process, how the epithelium is divided. Okay. So here you can see that there are three histological sections seen. These three histological sections depict three different layers. Okay, so the topmost layer. So first we will see the uh, orthokeratinized layer, which has four layers, which we have discussed. The four layers are the basal layer. The basal cells, you can see that they are darkly stained, dark blue. They are dark blue because they have a high mitotic activity. They have large amount of cellular organelles, so they are high in mitotic activity and they are rapidly proliferating. So this is the basal layer. Here you can see the prickle cell layer or the stratum spinosum. Next you will see a granular layer. Now here you can make out that the cells are getting more flattened and the nucleus is lightly stained because the nucleus is getting destroyed and the cell organelles are also getting destroyed. In the topmost layer there is a keratinized layer or stratum corneum. This is your orthokeratinized layer. This is the, this is the parakeratinized. This is the orthokeratinized layer. Sorry, orthokeratinized. Now here what is happening is, see, it has the stratum basale, the cells, and here the cells are getting destroyed, and here you will not see any nuclei. Right here you will not see any nuclei in the keratinized layer. This is the orthokeratinized layer. This is present in the gingiva, attached gingiva, and the gingiva of the palate. This type of gingiva. Now let us talk about the parakeratinized layer. The only difference is it has pycnotic nuclei. So here you can see that some amount of nucleus is still retained by the corneocytes. Here the nucleus is completely destroyed, but here it retains some amount of nucleus. It is, you will remember, P for parakeratinized, P for pycnotic nuclei. So this has some amount of nucleus retained in the topmost layer. This is the most layers of the oral cavity or oral mucosa are parakeratinized. Most of the oral mucosa is parakeratinized. Next is the non-keratinized layer. Non-keratinized, and here you will see that there is no non-keratinized layer. And here you will see that there is no keratin, right? And the basal cells are common. The prickle cell layer is common, but this does not. Non-keratinized epithelium, remember, this does not have stratum granulosum and stratum corneum are absent in non-keratinized layer, and non-keratinized epithelium is present in, it is present in caul area, and sulcular epithelium. It is non-keratinized. And so not cold, it is call and sulcular epithelium. Both these layers are non-keratinized. A non-keratinized layer means keratin, the stratum corneum is not present, and we studied that stratum corneum is responsible for taking all the stress. It acts as a physical barrier. So if that physical barrier is not present, that those areas become more susceptible to infection. Okay. So this was about the keratinization. Now let us see the non-keratinocytes which are present in the oral epithelium. Non-keratinocytes. Apart from the keratinocytes, the other cells which are present are called the non-keratinocytes. Majorly there are three non-keratinocytes which are melanocytes. These melanocytes are present in the basal and spinous layer. In between the cells, they will be present, these melanocytes, and they are responsible for production of melanin. Production of melanin from melanosomes. Next is the Langerhans cells. Langerhans cells. And these Langerhans cells are the antigen presenting cells. These are the antigen presenting cells. Mostly they are present in the suprabasal layer, means they are mostly present in the spinous layer here. And what is the role of these? They are antigen presenting. So whenever a bacteria which cannot be stopped by the epithelium, the stratum corneum, and if it enters the oral epithelium, the body needs to identify, okay, something noxious has entered the oral epithelium. So that toxin, that bacteria will be identified. What it will do, it has certain receptors. The bacteria has certain receptors. Also these antigen presenting cells, the Langerhans cells, have receptors. So they will identify each other and they will bind with each other. Now these antigen presenting cells, these Langerhans cells will present these bacteria either to T cells, B cells, or macrophages, right? So this is the function of Langerhans cells. Now comes the Merkel cells. These Merkel cells are present in the basal layer. Merkel cells, these are present in the basal layer here, and they are responsible for sensory function. These are present here in the basal layer like this, and these are connected with the nerve fibers which are coming from down, and they are linked with the nerve endings. Thus they are responsible for sensory functions of the oral epithelium. They are responsible for the sensory function of oral epithelium. Okay. Now let us come to one important topic, which is the keratin proteins. Right now we are studying about various keratin proteins which are present there, right? So there was various studies done to find out which type of keratin proteins are present in different layers of the epithelium. So the next topic is cytokeratins. Cytokeratins. Why are these called as cytokeratins? These keratins are responsible for maintaining the cytoskeleton of the cell, the structure of the cell. The proteins responsible for maintaining structure of cells are called as cytokeratins. Okay, guys, listen to this. It is very important for MCQs because it is asked. Okay, so I'll tell you the different, these cytokeratins are divided based upon their molecular weight from highest to the lowest. Okay, so there are cytokeratins K1, K2, K10 to K12. So these are called as epidermal These are called as, write it down somewhere because this is the most difficult thing to remember. Okay. Epidermal type differentiation proteins. Differentiation proteins. These cytokeratins, these K1, K2, K10 to K12. So how you will remember it? Remember एक protein भी याद रहेगा K1 and K2. So K1, K11, K10, K2, K12. Okay, K1, K2, then K10, 11 and 12. 1 and 2 you have to remember. Okay. So they are expressed with high intensity. They are expressed with high intensity in orthokeratinized areas. Orthokeratinized areas and less in parakeratinized. Important point. Okay. They are highly present in orthokeratinized layer. Means they are in high amount in stratum corneum layer and they are less in parakeratinized area. Okay. Now the next point. The next type of cytokeratin which is important is K6 and K16. K6, see जो भी प्रोटीन है ना, जैसे ये है 1 and 2, तो उसके आगे 0, 1, 2, 1, 1 like that. Okay, similarly K6 and 16 are together. ठीक है. Now K6 and 16, they are characteristics of highly proliferative epithelium. They are characteristic of highly proliferative epithelium. Next comes the K5 and K14. K5 and K14, they are stratification specific cytokeratins. They are stratification specific cytokeratins. These are present in outer epithelium. Okay. And lastly is K19. K19 is absent in orthokeratinization and present in parakeratinized. Okay. Remember this point. K19 is absent in orthokeratinized and it is present in parakeratinized. Okay, guys. Now, next question. The next topic is the basal lamina. The basal lamina. We studied the oral epithelium, right? This oral epithelium is connected with the underlying connective tissue with something which is called as basal lamina. So this thing, this yellow structure which you see here is your basal lamina. Now these cells are connected with the basal lamina with the help of hemidesmosomes. These are connected here with certain connections which are called as hemidesmosome. This is hemidesmosome. So hemidesmosome, hemi means partly it connects the cell and partly it connects the basal lamina. So anywhere, whenever the cell is connected to the basal lamina, remember it is connected with hemidesmosome, and when one cell is connected to an other cell with desmosomes, hemi गायब हो गया, hemi is not there. Direct connection between two cells is with the help of desmosomes and the connection of cell with the basement membrane is with the help of hemidesmosomes. So now this basal lamina, this is 300 to 400 angstrom thick. Remember this point. This basal lamina is 300 to 400 angstrom rich, thick, and if this is the cell, okay, this is the cell, here is the basal lamina. This basal lamina is made up of two layers. The above layer The above layer that is towards the cell is called as lamina lucida. This layer, this part is called as lamina lucida. And below this is called as lamina densa. Lamina densa. Now, see, lamina lucida is rich in laminin protein. Laminin protein. This is important for MCQs. That's why I'm telling you. Now, let us see the structure. Okay, that part is not there. So, see, this is connected. I told you this cell is connected with the basal lamina with the help of desmosomes. So, here is the desmosomes. These desmosomes have something in this cell which is called as tonofilaments. Which is called as, this is called as tonofilaments. Okay, and here this lamina densa, why this layer appears dense? Because it is rich. It is rich in collagen type 4. There is braiding. The collagen fibers are intermingled among themselves like a braid in lamina densa. Therefore, it appears dense or darker in color. Therefore, it is called as lamina densa. It has collagen type 4. Collagen type 4. Now, below this, here, there is a fiber which are like this. From the connective tissue, they will come to the basement membrane like this. These are called as reticular fibers or collagen type 7. These are called as reticular fibers or collagen type 7. Okay. So here in the lamina densa, there are two collagen. Number one is collagen type 4, which forms the layer, and there is reticular fibers which are coming from the connective tissue and getting inserted into the lamina densa. Okay, thus what is happening? What is the role of these? These are anchoring fibers. Okay, these are anchoring fibers. What is the role of these anchoring fibers? These anchoring fibers are responsible. These are the anchoring fibrils, and these anchoring fibrils, they are responsible for holding the basement membrane, the cell, to the connective tissue very firmly. Okay, that is the role of these anchoring fibrils as the name suggests. So, lamina densa has collagen type 4 and anchoring fibrils which are collagen type 7, and lamina lucida is rich in laminin protein, and they are connected to each other by hemidesmosome. These two cells, the keratinocytes, are connected with each other with desmosomes. Remember this. This is an important point. Okay. Now, the last important part of this topic is the junctional epithelium. The junctional epithelium. This junctional epithelium is a very unique epithelium. This junctional epithelium is a very unique epithelium. So why this is very unique, that we'll see now. So I hope the image is clear. Okay. So this junctional epithelium, you can see here, this is the tooth, this is the cementum, here is the connective tissue. So this is the only epithelium. Junctional epithelium is the only epithelium in the whole body which has two basal or basement membrane, which has two basement membrane. Okay, so what is this junctional epithelium? This junctional epithelium is located below the gingival sulcus. This junctional epithelium is located beneath the gingival sulcus here. Here you can see this blue thing. This blue thing is the junctional epithelium, and it is located at the apical end of the sulcus. Okay. So, this junctional epithelium is located below the sulcus. So, it surrounds the true tooth like the sulcus only. So, it is like a band collar around the tooth which holds the sulcus and the connective tissue to the tooth. Okay. Now, this junctional epithelium in normal healthy gingiva is present at the level of CEJ, but as the age increases, this junctional epithelium comes down because of recession or because of supraeruption of the teeth. This layer is made up of, in the early life, it is 3 to 4 cell layer thick, 3 to 4 cell layer thick, but as the age increases, as age increases, the thickness increases. The thickness increases till 10 to 20 layers. The width of this junctional epithelium is, this is important, the width of this junctional epithelium is 0.25 to 1.37 mm and the average is 0.97. If a range is given, then this will be the answer. If only a single value is given, then this will be the answer. Okay. So, the width of junctional epithelium is approximately 0.97 and it has two basal lamina, I told you. So, let us see how it has two basal lamina. One basal lamina is here. This part you can see here. This is the connective tissue. So, it is one basal lamina. This basal lamina is called as the external basal lamina. External basal lamina. This is connected to the connective tissue on one side. Okay, this also has a basal layer and a suprabasal layer. The junctional epithelium has a basal layer and a suprabasal layer. Then the cells which are here, these cells which are here besides the enamel of the tooth, these are called as these cells, enamel and cementum of the tooth. These cells are called as DAT cells. What is this DAT cells? DAT cells are directly attached to the tooth cells. The cells which are directly attached to the tooth are called as DAT cells. Okay. This is the external basal lamina. These are the dead cells, and on the inside, this blue structure which you see here, this is the internal basal lamina. This is the internal basal lamina. So, it has two basal lamina. These basal lamina, so the junctional epithelium is connected to the tooth surface with the help of basal lamina, and whenever there is basal lamina and the cell, the connection is with the help of hemidesmosomes. We just now we studied, right? Just now we studied this. So, here these cells are connected to the basal lamina with the help of hemidesmosomes. Okay, here also hemidesmosomes are present. The connection between cell and basement membrane is with the hemidesmosomes. Be clear with that. Okay. Now, there is something which is called as biologic width. What is this? Biologic width. And another very important and confusing part, right, of gingiva. So, if this is the tooth, here is the sulcus. This was the junctional epithelium, right? This was the junctional epithelium. Here is the bone. So, this part, this what you see here, this is the junctional epithelium, and the width of the junctional epithelium average we studied is 0.9, right? Now, below the junctional epithelium, below the apical end of the junctional epithelium, there is connective tissue. The width of this connective tissue is approximately 1.09 mm. So, the total of this from the junctional epithelium up till the alveolar crest, this is your biologic width is equal to 0.97 plus 1.09 is equal to 2.09 mm. This is your biologic width. So why this biologic width is important? Why this biologic width is important? This is important because whenever there is whenever we are placing our crown or any restoration, cervical restorations we are placing, right? If that restoration or if the crown is encroaching the biologic width, means if the crown is placed here, if this is the crown, okay, here is the, this is the biologic width. The level of the crown should be till here. But I have made a crown which is encroaching my biologic width and it is reaching till here. So what I am doing? I am irritating the connective tissue. If there is any sort of irritation to this connective tissue, what will happen? There will be inflammatory response and thus there will be destruction of the connective tissue. There will be destruction of the alveolar bone. So sometimes this is important for your clinical practices. So whenever you are practicing in clinics and a patient suddenly comes to you after placement of the crown with a localized periodontal swelling or a localized gingival swelling. That swelling, the first thing you must think is that either my material, the cement has gone inside the connective tissue here below the junctional epithelium, or the crown is extending subgingivally very much. So you need to make a new crown. So that is very important. Even in the cases of crown lengthening, you should know till where your crown lengthening should be there, right? So this is the importance of biologic width. The biologic width should be maintained. It should not be encroached by the restorations, by the prosthesis or anything, because if the biologic width is compromised, the chances of inflammation and bone loss will increase. We have to protect the biologic width. Okay. So this was the these were the important things about the gingiva and the gingival connective tissue, biologic width. Now the fibers which are located here, this whole junctional epithelium plus the connective tissue above the alveolar crest, this is called as dentogingival unit. This is called as dentogingival unit. Dentogingival unit. Okay, and there are fibers which are located here. These fibers are called as gingival fibers. So in short, we will read about the gingival fibers as well, and after that we will take a break. So gingival fibers, these gingival fibers, they are divided into two: principal fibers and minor fibers. The principal fibers were given by Arnin and Hagerman. Arnin and Hagerman. And the minor fibers were given by Page et al. Page et al. Okay. So to remember the principal fibers, what are the gingival fibers which are included in principal fibers? There I have made a mnemonic so that you can remember. It is DAGS CT. Okay. In this, D is dentogingival, A is alveogingival, D is dentoperiosteal, dentoperiosteal, C is circular fibers, and T is transseptal fibers. Now transseptal fibers, some consider these transseptal fibers to be a part of periodontal ligament. Some consider them to be a part of dentogingival unit or gingival fibers. But guys, mostly these transseptal fibers are a part of gingival fibers only because they are not located into the periodontal space. They are located above it. Transseptal fibers connect to adjacent teeth. Okay. So let us see how these principal fibers look. So if this is the tooth, okay. If this is the tooth and here is the alveolar crest. Now the dentogingival, as the name suggests, it extends from the tooth to the gingiva. So this is your dentogingival fibers. These are your dentogingival fibers. Now dentoperiosteal. Dentoperiosteal are the fibers which extend from the tooth to the periosteum of the bone. So these are your dentoperiosteal fibers. Next, the alveogingival. As the name suggests, these fibers extend from the crest of the alveolar to the gingiva. So these are your alveogingival fibers. Then there are circular fibers. The circular fibers are seen in the cross section. They are surrounding the free gingival margin. So what is the role of the circular fibers? They are surrounding the free gingival margins. Thus, they are adapting the free gingival margin closely to the tooth. That is the role of the circular fibers. And lastly, there are transseptal fibers. These transseptal fibers are the fibers which are present between the tooth, right? Between the tooth. These are the transseptal fibers. Now, the fibers, these gingival fibers, the transseptal fibers plus the dentogingival unit fibers, these are the fibers which can be regenerated even after they are cutted, means even after they are cut. Okay, so the fibers of dentogingival unit can be regenerated after they are cut. And one more important point that is here is supracrestal fibrotomy. Supracrestal fibrotomy. What is supracrestal fibrotomy? This is a procedure which is done in orthodontics. Orthodontics to prevent relapse of tooth movement. To prevent relapse of tooth that is moved. Okay, so what we do in supracrestal fibrotomy? What we do in supracrestal fibrotomy? If this is the tooth, here is the free gingiva. So we insert the blade inside the sulcus. We take the blade after giving the infiltration. We insert the blade inside the sulcus and take it up till the alveolar crest. So all the fibers, all the gingival fibers, all these fibers which we studied right now, all these are cut in supracrestal fibrotomy and they take a time, a specific amount of time, 3 to 4 months to regrow. During that period, the relapse of the tooth can be prevented. Okay, so that is what is supracrestal fibrotomy. Now the minor fibers, there are other fibers, they are not that important, but I'll just enumerate the name of the minor fibers. For minor fibers to remember, you can remember pits in India. So the minor fibers are periosteal fibers, then interpapillary fibers, then transgingival fibers, then intercircular fibers, intergingival fibers, and semicircular fibers. So only the name is important. These are not that much important fibers to remember. Okay. So with this, we have completed our topic of normal anatomy of gingiva. And now, guys, I'll just take 5 minutes to see if there are any doubts or not. Uh, uh, okay, so it is 7:40. We'll take a 10 minutes break and then I'll see the doubts in the meanwhile and we can clear the doubts for 5 minutes. Okay, so we'll meet right now. It is 7:40. We'll meet at 7:50 sharp. Okay, guys. So by then, all of you, those who have not joined the Telegram group, can join the Telegram group. And after this, we'll be having our session on our normal live application only. So thank you so much and take care, guys. Bye bye. कट हो ना कट हम्म